For everyone who's tuning in just now, and for those coming in, Anu is our supervising PA at Lenox Hill, and she's phenomenal. And I think this is an extremely enlightening talk where she's going to go over basically a day in the life of what she does here. I've said this before, but the Lenox Hill PA service is a very unique service. There's a lot of autonomy. They've been extremely well trained. And compared to where I trained in the PAs I worked with previously, these PAs function as colleagues 100% of the time. And I mean, I find myself frequently running ideas by them as well, just because of their experience and their expertise. So Anu, you don't need me here. I'm going to let you run the show. And you've crossed 200 already. So,
yes.
All right, guys, have a great day. Otherwise, stay tuned.
All right, everyone. Thank you, Dr. D'Amico, for that intro. So we met, I think, 2 weeks ago on the panel, and I wanted to kind of walk you guys through what my day looks like as an ACP. And for those of you that weren't here the first time around, ACP stands for Advanced Care Provider. And this can be a nurse practitioner, a physician assistant, or CRNA, which is a certified nurse anesthetist. And we basically function as extensions of the physicians, and we do practice independently, and we have a lot of fun doing it. So let's talk about how our day goes. And this isn't going to take up the whole hour, because the first time around there were a lot of questions, so I wanted to be able to leave room for whatever questions you guys have. So let's get started. Okay, so let's talk about me first, because I feel like everyone's journey is really important. So I started off as an athletic trainer. You could see me here in my past life on the football field with my former boss. An athletic trainer, for those of you who aren't familiar, are the people that run out onto the field when someone goes down and has injuries. I participated in the rehab of athletes, evaluating their injuries, smelling their nasty feet, and the whole gamut of what it takes to run a sports team. So we are keeping the athletes healthy. So I really loved what I did, but I wanted to kind of move on and be a little bit more. And so when I went to PA school, I worked throughout PA school, and I started my journey at Cooper University Hospital, which is in Camden, New Jersey, which, for those of you in America and on the East Coast, know that Camden, New Jersey is a very rough neighborhood. So I saw a lot of gunshot wounds. I saw a lot of high impact car crashes. It was a level 1 trauma center. So I saw a lot of very intensely injured patients. And then I trekked out to the central Pennsylvania, which is up here. This is Geisinger Medical Center. It's a beautiful hospital, and it is huge. And this picture is Pennsylvania up here in the top right corner. It's the geography that Geisinger covered. So this isn't all of Pennsylvania, but it's 2/3 of Pennsylvania. So we saw a lot of patients that got choppered in from everywhere in this area. So that in itself was an amazing experience. Also, it was a very well-run institution. They were very ahead of their time with electronic medical records, and everybody in this geographic area is part of the same electronic record. So, someone would get choppered in from, a 3-hour drive away, and before they even hit the door, I knew everything about them because all the electronic medical records were one. So it really made for a super efficient service and hospital. And I was really happy to have really launched my career from here. And there too, it was a very ACP heavy practice. We had neurosurgeons. We didn't have a lot of residents at all. And so this is where I learned how to operate. This is where I learned how to do bedside procedures. And it really laid the foundation for me. After a while, I decided that I should kind of live the life I wanted, which I always knew I was going to end up in New York City. But once I felt like I was very well trained, I went back and I started my New York career as a PA at Beth Israel Medical Center downtown. I really loved it there. Also, a very ACP heavily run service, and then I eventually transitioned to Lenox Hill, which I've been at for about 6 years now, and I love it here. I love the surgeons. I love my team. It's even administration. It's a very, very unique hospital in that it has like a very community centered vibe to it. But we also do a lot of tertiary care type surgeries, and it's a great place to work. So let's talk about how we work. So our days start at 6:30, and for an hour we hand off the service. So we have the night PAs handing off to the day team, and this day team includes PAs, a nurse practitioner, residents. We have visiting residents from our one of our main hospitals, Manhasset, which is out in Long Island. They are PGY fives. So PGY means postgraduate year. So these are senior residents that are in their 5th year of residency. So they are kind of practicing how to be attendings at this point. And then we have fellows. And for those of you who don't know the hierarchy, there's med students, there's residents, and then once you finish your residency, you go on to a fellowship where you specialize even more, and then you become an attending. And that's when you're kind of independent and starting your own practice or joining a practice. So we do sometimes have attendings join these rounds, neurosurgeons and neurointensivists. So it's a very comprehensive handoff. We go through everything about the patient, from why they're here, how many days out of an operation they are, what is their medical problems from top to bottom, not just their neurosurgical problems, but everything that's keeping them in a hospital. Their social situations, who's making decisions for them, are they going to rehab, or are they going home? So it's literally just an hour of talking about every single patient on the service. And now, because of COVID, and I will tell you, a lot of these pictures that are in this presentation are pre-COVID. So if you're wondering why nobody has masks and we're all up on top of each other, it's because this was in a different world, literally. So what we have done is we've made our rounds virtual. So a part of it does happen in person, but I usually join through a virtual platform, and so do the attendings. Dr. Langer joins almost every morning so that he can kind of hear what's going on the service, identify any issues that maybe we need help with escalating. If there's some kind of difficult conversation that needs to happen to another surgeon, he helps facilitate that. And then after we kind of do the talking part of it, we walk and we see every single patient on the service as a team together. So we all have laid eyes. By 8 a.m., the entire team has laid eyes on every single patient on the service, and we're kind of triaging anything that might need to be addressed emergently. So this is Dr. Bookvar in one of his more goofier moments. We sometimes have to put our foot down that the attendings cannot bother us during this time, because we do have a very busy and hefty service, but sometimes we have them join and it's comic relief. This is Dr. Bookvar trying to sit on a chair that broke when he sat on it, so we were all helping him up. So he's a goofball. So conferences, this is very, very important to us for many different reasons. This is for our professional development as ACPs, as doctors. This picture that Dr. Bookvar tweeted was a while ago. This is pre-COVID, but this is our brain tumor conference. I know all of you guys have been attending a lot of our conferences. And you probably have realized how important they are, because we're literally talking about how we're going to treat a patient. So for brain tumor and cerebrovascular, these patients, they're admitted to the hospital, and you need all the minds that come from different teams and different specialties to make sure that we're delivering the best care to these patients. So not only is it helping decide how a patient's going to do and making sure that they're doing the best action plan of action, but it also is empowering us with knowledge. So I've been doing this for 13 years. There hasn't been one day where I can say I didn't learn something new. And that's really what everybody should be striving for, is that every day you're learning something new. Every day it's you're enriching your life and your mind some way. So a couple of the other conferences that maybe you haven't joined, we have mortality and morbidity, which is very important. So this is kind of like a quality conference, and I actually run this conference. It's a discussion of people that either passed away. Most of the time, we don't really have control over them because they come to us in such a poor state that we help them pass peacefully and with dignity. And then morbidity. Morbidity includes people that get readmitted to the hospital, people that have to go back to the OR for some kind of reason, people that get infections after surgery. So it's really kind of going through those cases with a fine-tooth comb and seeing where we could have improved our care, if we could have improved our care, did the standard of care, was it met for that patient? So it's really a way for surgeons to reflect on themselves and us to reflect on our processes. And a lot of good things actually come out of this conference because we've implemented new protocols, new ways of functioning, and that's just based on the discussions that happen at that conference. Then we have grand rounds, which is where we invite people from other institutions, other specialties to kind of give us more knowledge on things that we're doing. In-services are really important. Technology is a huge part of healthcare. So there's always some kind of new something that we have to learn about because they're going to introduce it onto the service. So arranging for the education around that is also very important. So education is a huge component of what we do on a daily basis. So these conferences happen in the morning. So after we've signed out and we've rounded, we have gone to conferences. So we have a very densely packed morning. So now we're at 9:15. So all of these things, we've enriched ourselves. We've talked about our patients. We've done so much already, and it's only 9:15 in the morning. So we do interdisciplinary rounds. So these are crucial. So interdisciplinary rounds there's representation from neurosurgery, and it's usually one of us, either a PA or Cynthia, our nurse practitioner, and then a neurointensivist, which I spelled that wrong. So we also have bed boards. So these are the people that manage how people move throughout the hospital. So if they don't need ICU anymore, they're going to a step down or a monitored situation, but they're not their care isn't as intense. And then taking people out of monitored beds and putting them in regular beds, so that because they don't need as much care, maybe they're waiting to go to a rehab. So they're the ones kind of navigating a patient through the different parts of the hospital. Then you have social work and care management. These are the people that are going to help get patients into a rehab, skilled nursing facility, if they need to be transferred somewhere else, or if they need services at home, because a lot of our patients, they don't need to go to rehab, but maybe they need a hospital bed at home. Maybe they need a walker that they didn't need before the surgery. So these people are really crucial to how patients do after the surgery and when they go home, because when they go home, we don't want them coming back unless they have to, only for good reasons, social reasons. Nurse managers. So they're extremely important because they need to know what's going on their units. They need to plan for receiving more patients from the OR. And then you have your physical and occupational therapists who are there to tell us whether or not people can go home, what their assessments are. Like, is someone needing two people to get up and walk out of bed, or are they independent? So these people are extremely crucial to how a patient does after their surgery or after being under our care. So, it's not, very, sexy like surgery, but it is, you could do the sexiest surgery you want. But if you don't have these people involved afterwards, it doesn't matter, because your patients need every single one of these people to make them do well. So we split off. Everybody has assignments during the day. So usually we have someone assigned to the neuro ICU. We have someone assigned to the floors. We have someone assigned to the ORs, and we have someone assigned to helping getting people out of the hospital. So the neuro ICU, as the name says, intensive care. These rounds are very intense, and they include a number of different teams. So you have the neurointensivists, you have the neurosurgery ACP, we have pulmonary critical care fellows, so people that are trying to become intensivists in the medical realm, but part of their education has to be neurocritical care. So they come do I think it's like 4-week rotations with us to learn neurocritical care. You have a pharmacist there to make sure that we're prescribing medications correctly. You have nurses there to tell us what's been happening with the patient. Because a lot of times, even though we have our view of what's happening with the patient, but we're not there 12 hours a day like the nurses are. They're literally at the bedside all the time. So they know the nitty gritty. So we can say, oh yeah, we're going to prescribe this medication. And the nurse may say, well, this patient can't even swallow. Why are you giving them these massive horse pills? Literally, those are the conversations we have. And it makes our care so much better because they know what the patient needs. And the nurses are true advocates for the patient. So, sometimes we, it's hard to admit this, but sometimes we are removed from what's actually happening with the patient. So it's very important that we know what the nurses are experiencing and their input to make sure we're delivering the best care. Nutritionists are really important. A lot of our neurosurgical patients, they don't necessarily have the ability to swallow after surgery. Sometimes it takes them a few days, or our stroke patients who might need a feeding tube. So we have to make sure that they're getting their correct caloric intake, and that they're remaining healthy so that they can heal properly. Some people, they don't have appetites because of their brain surgery. So we have to do calorie counts, and we have to make sure that they're intaking enough calorie by mouth. And if they're not, do we supplement them with food? So they're very, very important. And then students. We are an academic institution, not only for medical students, but for PA students, nurse practitioner students. So these rounds are very intense, and there's a lot of teaching that happens. The students usually are asked to carry their own patients, and they're presenting them. They're going through the charts just like we are. So it's a true practice of what their future will look like as a resident or as a PA or whatever it is that they're going to. So there's more rounds. So once you think you're done rounding, that means you have to round some more. So then you have the attendings coming by. In this particular patient, we have Dr. Langer, Dr. Ortiz, we have a resident in the background, we have Dr. Levine. So rounding with the attendings is really important, because sometimes then no matter how much you're at the bedside, the patient wants to see the people that were intimate with their brain and did their surgery. So it's very important for us to join them to make sure that we're witnessing those conversations, that we're on message, that everybody's on the same page, that we're making sure that the surgeons have all the information, and that they're going in, with a comprehensive understanding of what's going on with the patient. And so things that come out of these rounds, when do we take out drains, or are we continuing them? Family meetings are very, very important, especially neurosurgery, because sometimes our patients can't talk or they're intubated. So Sometimes you have the families making decisions for them. So it the meetings that we have with families cannot be stressed enough. Sometimes these meetings are held by us independently with the families, or depending on the scenario, the surgeon is involved, the neurointensivist is involved. So this is extremely important. Discharges, who's ready to fly and can go home. Consult management. There's a lot of patients on our service that that we follow that are on other services, like they're on the medical service and they were just discovered to have a brain tumor when they were here for something else. So, what is the plan? Are we going to operate on them while they're still admitted, or do we send them home, have them recover from whatever medical problem they're having, and then come bring them back for a surgery? Post-op checks, making sure that the people that had surgery are doing well that day. Transfers, we have people come in from all over the place. We have a very, if you could imagine Lenox Hill being the hub of a wheel, and then there's spokes that are coming in. We have multiple hospitals in Brooklyn and Queens and Westchester where they're all sending their patients in. So accepting a transfer is a lot of work, because we have to talk to the doctors that were taking care, or doctors at ACPs that were taking care of the patient at the other hospitals, and making sure that we have a comprehensive understanding of what we're receiving, and then making a plan for them. Some of them need lines. We have to put in central lines in the big veins in their neck, or we have to do emergent procedures on their head. So a lot of what we're doing during the day is when we're dealing with transfers, is gathering information and being detectives. And then the ER is open 24/7 for business. So a lot of times we get a lot of consults and we're going down to see them. And then the other thing is in the ICU, we have very sick patients, and with very important drains that, if they get pulled out, can be very bad for the patient. So we have to accompany them to the CAT scanner, or if there's an emergency situation, which more often than not in our world is the case. And so you want to be there in the scanner as the scan's happening to make sure either everything's okay, or if the patient needs to go to the OR, that you're starting that process of getting the patient to the OR. Okay, so the operating room. So this is kind of where I live most of the time, but it's, we have someone that's assigned to the OR. So who's helping in the ORs? We have the ACPs, we have the fellows and the residents. And this is out to, obviously, the neurosurgeons are the ones doing the surgery, but we're the ones assisting and learning. This is Dr. Levine. And this is Dr. Kim. She's our anesthesiologist, and we're just hanging out waiting for something. I'm not sure. This picture was taken a long time ago. So one of the most important things that I do as a ACP in the OR, these are not our patients. I just did a quick Google image search. This is one of the most important things about surgery is how you position them. If you don't do this correctly, you will struggle for the next 8 to 10 hours or however long the surgery is. And so this part of it is super important. And you can see here, we literally tape people into their position that they're supposed to be in. This is a very difficult, this top left, this is a very difficult position to get a patient in, because the patient is intubated. They're completely dead weight. So literally you need all hands on deck to get a patient into this position. You need the anesthesiologist to make sure that the airway doesn't fall out. You need the nurses, the neurosurgeon, the PAs, the scrub tech, anybody that's walking in the hallway, you pull them in, because it literally, this is so, I cannot stress how important it is to have a lot of people and have people that know what they're doing. Because when you're putting someone in a position like this right off the bat, I know that this is a surgery that's going to take a long time. Because when you're putting someone in this position, that means that you're getting something that's deep in the brain to the side, and you want to make sure that the patient is padded correctly. So you can see here, there's a lot of foam. Their hands are all cushioned, the head's cushioned, because anywhere there's a bony prominence, There is also a nerve usually following in close by in that area. So you want to make sure your patients don't wake up with an injury to a nerve. You don't want them to wake up with a problem they didn't start with. And also you don't want it to confound what you've done in the surgery. So if you did some kind of brain surgery or spine surgery and they wake up not moving their hand, you want to make sure that it's, yeah, is this coming from the brain? Is it coming from the spine? You never want to say, is it because I positioned the patient incorrectly and that their bony prominences were not padded correctly, therefore there's a nerve injury there because the patient was laying on the nerve for 8 hours. So I'm spending a lot of time on this because we spend a lot of time on this. Getting someone in these positions, in this lateral position, can take up to an hour. So it's a lot of work. This position down here, to the bottom right, this is someone this is someone getting a spine surgery, and you can imagine these patients are put to sleep on their back, and then you have to flip them over 180. So this also takes a lot of coordination, and making sure that you're doing it safely and that you don't dislocate their arms and that their breathing tube is staying in and it's taped correctly and it's secured. So this is where I come in quite a bit. And sometimes when I'm in the OR and I'm not scrubbed in, I just float through the ORs if we have multiple ORs, particularly at the beginning of the day for first case starts. And I'm just there to give a hand to position in multiple rooms because it is so crucial to do it correctly. And then there's the first assist part of it. So these are a lot of my team members. We have Guillermo, who you met 2 weeks ago in the angio suite. This is Vadim helping Dr. Langer. This was me. I think this was an emergent case. So I was getting the case started. This is me putting in screws in the spine. So, we do, depending on your skill set and your experience, you could, I'm not going to say independent because we're not independent in the OR, but you can do quite a bit to facilitate a procedure and a surgery, and make things very easy for the surgeon so they can come in and focus on the operation at hand. Then after the surgeries are done, post-op orders, we're responsible for it. And this is, and I mentioned this before, you could do the coolest surgery in the world and save someone's life, but if you don't continue that same dedicated care after the surgery, then you're going to not be successful. Whether you're planning on becoming a surgeon or a doctor or a PA, managing your patients correctly after the surgery is arguably more important than the surgery, particularly in cases like Dr. Langer does. Half the battle is getting them through that first 72 hours after a surgery, because if you don't manage their blood pressure correctly, people can stroke out. If you don't take care of their blood levels, of whether it's their electrolytes or how their blood makes a clot, you could really destroy an operation if you don't manage them correctly. And this is an example of an ICU patient that is requiring a lot of medications to meet the criteria needed to sustain post-operative care in neurosurgery. And also the other thing is people don't show up with just their neurosurgical problem. They generally have hypertension, they have diabetes, they have all sorts of other medical problems that you have to continue the care for that as well, and make sure it doesn't get ignored, because that could potentially impact the care that you're giving for neurosurgery. So you want to make sure that you're looking at your wounds all the time. If there are drains in there, what are the nurses supposed to do with those drains? Are they allowed to touch the drains? Because some of them, we don't allow them to manipulate the drains in any way. We are the ones in charge of it. Imaging, some of the surgeons, they don't necessarily want a CAT scan after the procedure, but some of them do. And if so, why are they getting it? Is there a concern that we should be watching out for? Do we need to get more specific imaging like an angiogram? What is their activity level? You know, I'd like to say most of our patients come out of the OR and they're doing really well, and you want to get them out of bed, particularly for spine patients. You want them moving as soon as you can. But sometimes, depending on what happened in the surgery or the nature of the surgery, they can't. They have to be on strict bed rest, they have to be flat. All of these things can potentially impact how they're healing, and the blood that's being delivered to their brain. So, you know, making sure that you have a clear directive of what your patients need to be doing after the surgery is very important. Pain control, pain, they call it oftentimes the sixth vital sign. If people are in pain, they're not going to participate in rehab or physical therapy. If they're in pain, their heart rate will be high. Their blood pressure will be high, which a lot of times you don't want that because you don't want them bleeding into wherever you operated on. Um, and you also want to make sure you're preventing things. So you want to make sure that you're preventing clots forming in their legs. So we have something called SEDs, which are boots that have air that flows into them in sequence so that it pushes the blood out of their legs back up to the heart. You have you want to make sure you take care of their lungs. We have something called an incentive spirometer, where it's literally blowing, or actually taking in through a straw, and there's like a little meter on there so that the patient knows how much air they're bringing into their lungs, because you don't want the lungs to pancake on each other after surgery, which is very common. Bowel, you want people's you know, after surgery, people's bowels, they kind of shut down from the medication that's given during anesthesia. So you have to make sure that they're on a bowel regimen and that they are passing gas and that they poop. I know it sounds gross, but at the same time, it's one of the most important things, because if they don't, you can be set up with a major problem of someone being bound up, being blocked, and not being able to go to the bathroom. And it's just something that's very preventative. It's preventable, I should say. And if you don't do this correctly, like, your patients can be very, very uncomfortable and potentially have more serious complications from that. That's Dr. Levine. We try to have fun during the day. So then, like I said, once you think you're done rounding, you round some more. So a lot of times the surgeons, particularly Dr. Langer, will round multiple times throughout the day. And this is Dr. Langer pulling down a sign in a hallway because he didn't like that it said MSK, which, for those of you who don't know, is a hospital down the street. But MSK in this setting meant musculoskeletal reading room. So the reason why I put this up there is sometimes we get imaging during the day, like I mentioned before. We get MRIs, we get CAT scans, and given the nature of neurosurgery, we oftentimes look at our imaging ourselves, and we make our own interpretations and we act upon them. So we don't always speak directly with radiology to make decisions on scans. However, sometimes there are certain things where, like, I don't know what I'm looking at, or I need a little bit direction. And that's when we walk down to the neuroradiologists and we sit down with them and we tell them to go over the scan with us. And Dr. Langer, who's been doing this forever, still goes down and still learns more and still is someone that is humble enough to say, I don't know what I'm looking at. I need an expert to tell me. And you know, you guys have been sitting in on our conferences in the morning, and radiology runs those conferences, and they really give very comprehensive detail about what we're looking at. So you know, I think I'm going off on a new tangent. One of the most important things you guys can do, no matter what career path you take, is know what you don't know. Be humble. There is no need to be confident when you're not confident. And I think that's probably one of the most important pieces of advice Well, actually, the first piece of advice I was ever given was trust nobody. And then the second piece of advice was know when you don't know. And I think that's just good life advice. So going back, so in the evening, we are following up on labs, imaging, consults, who left the building, if they were slated for a discharge, why didn't they leave? Because for us, in hospital administration, we have to answer to other people as to why are our patients staying in the hospital longer than they need to? Why, why didn't they go to rehab? So there's a lot of people we have to answer to outside of our clinical team. We have a lot of administrators that look at metrics, because at the end of the day, money is what matters, and we don't want people staying in the hospital longer than they need to be, and we need to make room for more patients to come in, specifically patients that are having surgery. Let's see what else. So we want to make sure that at night we kind of have a skeleton crew. There's we don't have as many as bodies in the building. So you want to make sure that before you're leaving, the patients are tucked in. So you've answered their questions. You have them anticipate their discharge for the next day. You are making sure that their pain regimens are good and that they're comfortable moving forward, because then that really helps the night person out, because the night person is managing a huge service. They're seeing consults. The last thing that you want to be a team player, you want to make sure that you're preventing any calls, unnecessary pages to your team members at night. And then we sign out at 6:30 at night. So that is another hour-long sign out of every single patient to the night person. Another part of what we do 24/7 is emergency procedures. So people come in a bad way, like this patient this isn't our hospital, this is somewhere else. But it takes a team. This is what it looks like when someone that's coming in and they're literally dying. And one of the most important things that we do as ACPs is an emergent procedure called an external ventricular drain. And this, I'm not sure how much you guys have heard about this. I know you guys are getting a lot of neurosurgery here, but as a quick kind of storyline here, there is a designated point that we know we can pass a catheter into the center of the brain that allows us to drain fluid safely and save people's lives. Literally, people will be dying and you put a drain into their brain and they wake up and they say, hey, what the hell is happening? That's literally happened to me multiple times. So where do we do this procedure? So this is a schematic, this top left. What you're seeing here is you're looking at a patient from the top of the head down. And what we're looking at here is the nose, and this is the midline, and this is the coronal suture. So everybody, if you guys press on your head, you can all feel your coronal suture. It's kind of a flat line. Most people can feel it. But anyways, that is a landmark that we use because we know that if we stay in front of this coronal suture without making any kind of measurements, that you're safely going to be able to enter the skull and the brain without potentially hitting the motor strip, which probably lives right about here. And then also you don't want to do it in the middle because you have a big sinus, which is a draining vein that's very bloody that you do not want to hit. So that's why you kind of go off to the side. So the measurements, and sometimes this can be variable, but it's 11 centimeters from your glabella, which is this point right here, the middle between your eyebrows. You go 11 centimeters back, and then you go 3 centimeters to the right. And we choose the right side because most people in the world are left brain dominant, even if you're a left-handed person. So that's why we choose that point, because we know you're likely going through non-eloquent brain, and you can safely pass a catheter through the brain. So essentially what you do is you make a small incision, and then we have this twist drill that looks exactly like this, and there's a bit that goes in here, and you make a hole in the head, which is the size of the tip of a ballpoint pen, and you pass a catheter through it, and your aim is to hit the ventricle. And you want to ideally hit the foramen of Monroe, which is where the two ventricles of your brain, they communicate at this one place so that you can drain both of those ventricles. So this is a life-saving procedure, and this is something that we do at the bedside. We do this either in the ER, we do it in the ICU, and it's very important to know how to do these because it can really impact a patient. And like I said, it literally saves your lives. So at the end of the day, there is no I in team. I'm sure you guys have all heard that, and it's corny, but it's true. We are a family here, and yeah, the surgeons are really important. They're the ones doing the surgeries, but as you saw from this presentation, you can't do neurosurgery without having multiple team members involved from multiple different places. And one of the important things that we've learned is to take care of each other. Particularly after COVID. COVID was very rough on us, and we have to know when to take a step away from work and just enjoy each other and decompress. And we try to do that. We have gatherings outside of work. We have fun holiday parties, and we really we work really hard together, and we play really hard together, which is very unique. That doesn't happen everywhere. I've been a lot of places, and working at Lenox Hill is truly amazing. And down here in this bottom corner here, this is actually I think you might have met Dr. Coleman and Dr. Baker. These are our chief executive officer, chief medical officer. This was a patient that actually, this is a patient and his wife who had brain surgery, and he had a very rough course because he became delirious afterwards, and now is completely normal. And every Monday, the hospital has a huddle, and all the leaders from the different departments are there, and we actually invited this patient to come to share his experience, for the wife to share the experience too, because she was rightfully very scared because she didn't recognize her husband, who was literally delirious and kind of talking nonsense. Everybody was worried, but this commonly does happen, unfortunately, in neurosurgery. But he had a great outcome, and they really wanted to showcase what a great job our team did. And in this group, you have nurses, you have physical therapists, you have the ACPs, you have Dr. Bookvar. It takes a village to take care of a patient, just like it takes a village to raise a child. So this is really, really important. So that's all I have for now. And I think we have 15 minutes. So Josh, if you haven't
Yep, I just opened the chat up for you.
Okay.
If you want to go back to your first slide so you can keep your Instagram handle up.
Josh is very good to me. Let's see. Can you discuss the role of palliative care in the neuro ICU, and do you work with any palliative care PAs? So palliative care is very, very important. And what I will say is that in the ICU, a lot of the critical care doctors, that is part of their training, is having those palliative care discussions. But that doesn't mean that we don't get palliative care involved. We actually rely on them very heavily. And I think something that's important to message here to you guys, so that you can go spread the knowledge, is palliative care does not mean end of life. Palliative care does not mean patients dying. That might be the case, but palliative care is more about comfort and support of the family and the patient. So they actually are very critical, because that's all that they're focusing on. Whereas in the ICU, we're focused on procedures, interpreting labs, stabilizing patients. And yeah, we have family discussions, but it's a very limited, amount of time. And this is please don't take this the wrong way, but sometimes spending an hour with the family members means that you're probably neglecting another patient. And so, yeah, it's important to have those discussions, but sometimes there's a lot of social situations that you have to deal with, of parsing out what did the patient want. Like if it's an end of life situation and the patient can't communicate, having that discussion with the family. And sometimes you're having the discussion with multiple siblings. There's strife between the spouse and the siblings, or there's nobody at all, there's just a friend. Unfortunately, that happens a lot in New York City, where people have lived their lives alone and there's nobody really there to take care of them. So palliative care is super important because they help us have those discussions. They can dedicate the time that's needed for it. So our palliative care at Lenox Hill, they actually utilize an NP, but that's not to say that you can't have a PA in that role. It just so happens that here we have NP. So ACPs are prominent in palliative care. And for those of you that might potentially be interested, there are palliative care fellowships out there for ACPs, so that you really learn how to have those conversations in a very empathetic and caring way. How do you handle yourself mentally when dealing with high pressure situations that require critical care? So this, I think, is a personality thing as well. I am an adrenaline junkie. So, if I know that about myself. So for me, when I'm in a critical care situation, I am not focused on anything else but what's happening in that moment. And that's what you have to do. You cannot be distracted by anything else. And you also have to learn how to be, I think part of handling yourself is being authoritative and being a leader. I tell my team every single time we have a meeting that as a neurosurgery PA, even if you don't have a title like mine, which is supervising PA, which by the way just means I get yelled at. I'm the person that gets yelled at. That's all it means. But when you're in neurosurgery, you have to be a leader. Sometimes you're the only person in the room that knows critically what might happen to a patient if they're not handled correctly because they're a neurosurgical patient. So being a leader and having that mindset, being confident in giving direction to others, delegating tasks, being able to prioritize what needs to be done first in a very critical situation is extremely important. And that comes with putting yourself in those situations to begin with. You have to be uncomfortable to grow. You have to be uncomfortable to learn how to manage mentally. You have to fail at doing that. And that's how you learn that. And being able to take critical feedback is really important to your development, no matter what you do in life. You have to know where you screw up, and you have to be able to hear that from other people. And that's I think very important. Let's see. What do you I love about my job? I think what I love about my job is I have no idea what I'm walking into every single day, which it's a love-hate relationship, because sometimes I hate that, but for the most part, I love it. I could come in thinking that I'm going to spend my day in meetings, and then I end up dealing with a ruptured aneurysm, and I'm putting in their drains, I'm putting in their lines, I'm getting them to the OR, coordinating family discussions about what the next 2 weeks is going to look like for that patient. And then once that's done, I'm in some boring meeting again. But I'm decompressing. So I think the unpredictability of my job is what I love, because I think as a person, it has helped me handle anything really. I shouldn't say that in a way of being overly confident, but it really helps me in my personal life. I'm a new mother, so like letting things roll off my back. I think being in neurosurgery and living this kind of unpredictable, kind of roll with the punches things has made me a better person. Let's see. Do you ever feel out of place in a hospital team? How do you know to transition to a new place? I think what's really important when you're in school and you're on your clinical rotations, one of, yeah, you're learning the clinical stuff, but you also learn a lot of life skills of how to insert yourself into a hospital team. I think that in itself gets you prepared. A lot of programs, they have their students rotate in different hospitals. And I think when you guys do that, it's really important to make sure that you're paying attention how you assimilate into that hospital. How do things run? How do you get shit done? Like that's one of the most important things that I learned very early, of how do you get stuff done? How do you know the right people to get that stuff done? And being able to recognize that early, no matter where you go, makes you very valuable. When you learn and you're proactive about doing stuff, being humble. So, if a patient needs to get to the OR, but they have to go to the bathroom and they need to go to the bedpan, go get that bedpan and put the patient on it. Like, you are not above that. If you're a neurosurgeon, or if you're an ACP, or if you're a patient carried, like, you have to, one of the things I think that has made me very successful, particularly in the OR, is I learned how to do everybody's job in the OR except for the neurosurgeon, obviously, and the anesthesiologist. I'm not a doctor, but I know how to move them along. I know how to move a room along. I know how to put a Foley in. I know how to do everything that the nurse is doing, and I know how to do everything that the surgical tech is doing. And that in itself made me very valuable. And I think you all can take something away from that, to be successful in your careers. What PA program did I attend? I attended UMD&J, which is now Rutgers. Very good program, very difficult. What are the consequences of making a mistake? Have you ever made one? Yes, I've made a lot of mistakes. Everybody has to make mistakes in order to get good. I can't say that I've made a mistake in where someone lost their life, but I've definitely made mistakes that had affected patient care. And I felt horrible afterwards. And I never forgot that feeling. And I never made those mistakes again. So I think, that's kind of a loaded question of what are the consequences of making a mistake. But I want to tell you guys that you have to make mistakes in order to learn. Let's see. Can you speak to your working in Canada? So I love working in underserved communities. I did my master's in Newark, New Jersey, which is also a very underserved area. I just love working with minorities. I love working with diverse communities. I feel like I connect with them very well. And Camden was like certainly an eye-opening experience. It wasn't the first time I was in kind of like a ghetto area where there's a lot of poverty, there's a lot of crime, and it impacted my career because it really made me. I did not grow up that way. And I'm someone that likes putting myself in different situations and trying to see the world through someone else's eyes. And working in a place like Camden really took me out of my element and forced me to see how other people lived and to put aside any judgments that I had about people, because I think it made me be more of a human when caring for these patients. Why is the role of a PA important? And they do not exist outside of the USA. So in the United Kingdom, they actually do exist. They started a program, I think it was like 5 years back in Aberdeen. But it takes a long time for PAs to function the way they function in the US. And the history of it was medics that came from the Vietnam War. And they were not doctors, but they were highly trained individuals. And that's kind of where PAs come from. And I bring this up because that's where our value lies, is that we aren't doctors, but we work so autonomously and we work as extensions of doctors that it allows doctors to be more productive. It empowers us to work autonomously and have a high level of education. And I think they should exist in other countries. I know nurse practitioners exist in other countries, but it's really like a culture shift. It's not something that I think gets embraced very easily, because it's very, traditionally, the very traditional mindset is that doctors are the, they're the end all and the be all of care, and they're the ones making decisions for patients. And that's not true in the United States, where, ACPs are relied on heavily. A lot of times, like Randy said at the beginning, we are asked what our opinions are. Dr. Langer introduces me as his partner to people, because we work so closely together, and there is value in our experiences outside of the operating room for neurosurgical patients that bring value to the overall experience of our patients. So that's why I think that they should exist. And what time is it? Okay, I think I have 2 minutes, and I want to address the burnout, because this is something that came up a lot in the first panel lecture. So burnout is something that's very real. And I think it's, I mentioned, having a great team is really important in this, because as a team member and as a leader for my team, I need to recognize when other people need a break. I need to recognize where I can help someone out, and not really get in their way, and really be useful. When you have a team that works like that together, then you're helping people avoid burnout. But, we're a very busy service, and we just came off of the horrific experience of dealing with COVID. So, burnout is something that's constantly on my mind for my team, and making sure that you're having conversations that you recognize in your team members when they're about to burn out, and recognize within yourself when you're, when I first started, I remember I could not wake up early enough to get to work, because I loved what I did. I would spend hours upon hours at work. But then it came to a point where that just became the norm of me just working my tail off all the time, and then not wanting to wake up and go to work. And when I recognized that, that I wasn't as excited about neurosurgery as I realized that I was starting to burn out, and I realized that I needed to, that the job I was in was no longer a good fit. And that was a very hard decision to make, because I've loved everywhere I've worked. But recognizing that I could no longer sustain not having a work-life balance made me leave a job before. And I know I'm probably not giving you guys a really good answer, but the answer is you really have to self-reflect. You have to have conversations with yourself. You have to understand the feelings that you're having when you are no longer performing the way you want to, and recognizing what are your own personal standards of delivering care. And if you're not meeting it, why aren't you? And if you're burnt out, then every institution has employee assistant programs. There's, wellness is a huge thing right now because of COVID, which it should have been a huge thing all the time. But now it's truly at the forefront of protecting our employees and making sure that if they are burning out, they have the right resources and tools and experts to help manage them. Okay. So I think I am done, and this was great.
Thank you so much for joining us.
All right. So, and thanks for joining me on Instagram. I'm official. All right. I see Dr. Baum is on, so I'm hand it over to him.
Anu, that was great. Thank you so much. I have to say, for everyone on here, Anu is very sort of typical of many of the PAs I've worked with their level of commitment, passion, just their enthusiasm for the job. On the other hand, Anu is quite unique in the fact that what she's able to juggle and then be able to handle everything on the floor, everything in the ICU, everything from the administrative standpoint. And then next thing you know, she's scrubbed in the OR with a nicer headlight than I have, helping like 8 different doctors with like 12 different types of procedures and still managing everything at the same time. It's amazing. It's incredible. So you guys are quite fortunate to hear her speak to us. So thanks, Anu.
Thank you. Bye, everyone.